If there are two criteria in making a diagnosis of a positive peritoneal lavage. One is gross. As I mentioned before, if you aspirated before infusing non-clotting blood, or you aspirated fecal material or bile, then it is sine qua non for an injury to perforation to the haloviscus, there's vascular injury or perforation to the hepatobiliary tree. If not, then you infuse fluid. And then the graduation of the fluid is the color initially. When it's frankly bloody, then most probably it is positive. But if the color is like pinkish, then you have to resort into microscopic examination of the return fluid.
Is it a diagnostic test, or it is also a way managed, treating the patient?
Not for trauma. If it is positive, then you have to operate. It only screen out which patient have a significant intra-abdominal injury and which patients do not have. And the accuracy rate is high.
I can see your problem. I'm trying to analyze your problem. You were thinking that you might use the peritoneal lavage procedure as a management procedure. Okay. Yeah, if you want, no? If you are, let's say, let's be flexible. No? But we are hearing from the journals that the peritoneal lavage is being used for as a diagnostic tool. No? But you can. I think you can use it for, if you think it's necessary, no? You can use it for a lavage, per se, as a management, no? As a lavage. If you think it will be that useful, no? But you have to think of some situations in which you can make use of that needle or that catheter, leave it behind for a management, as a management procedure. But offhand, I cannot think of any.
Peritoneal dialysis, you can insert antibiotic through that tube. You can give antibiotic through that tube.
And so you can make use of that catheter if you really, if you think that, if you want to make use of that catheter for infusion of your antibiotic.
Yeah, as long as it's not indicated that the patient has to be opened up.
Yes.
I was a little intrigued by your statement that ectopic pregnancy is quite easy to diagnose because of the recent case that happened. Observation really is very important because in ectopic pregnancy, sometimes the patient bleeds vaginally, and then the obstetrician does a dilatation recurrence, and after that, the patient still feels complaints of pelvic pain, and just to avoid embarrassment of the surgeon, I must remind the surgeon to have continuous observation, because in this case that I have seen recently, the surgeon probably did only one or two examinations and missed the diagnosis, and also the obstetrician did not suspect the presence of ectopic pregnancy. The suspect there was incomplete abortion, and it turned out to be an ectopic pregnancy. This case was referred to a surgeon. And I will remind your young surgeons to do serial observation, because in this case, if serial observation was done, you will never miss the diagnosis. And for you who would like to do a DNC in a case of a vaginal bleeding with or without pelvic pain, it is mandatory to do a histopathological exam. Why? Because if it is a case of ectopic pregnancy, you will be given a clue in the histopath, because it will show a residual reaction, and you will not miss the diagnosis. And that is why our speaker said diagnosing and ectopic pregnancy is quite easy. But if you don't follow this rule of observation, serial observation, I will bet you are going to miss it.
I would like to ask both doctors how they feel about removing the appendix every time you open up the abdomen. I would like to know your reasons.
On my part, I won't. If there is no indication for removing the appendix, then do it. Especially if you have no consent. In the Philippines, malpractice is not a problem.
Let's say the consent was for an explorer.
Yeah, the consent was for an explorer, but not for an appendectomy. I will not do appendectomy if there is no indication to do so.
What about the other doctor?
The question is, what's your comment with regards to operation which you...
How do you feel about removing the appendix every time you open?
Well, you have to qualify your question. If there's an indication to remove the appendix...
Excuse me, I am qualifying my question. Let's say there is no indication, no? Let's say you went in because you were doing a cesarean, or you were doing paralysis, no?
Okay.
Or an ectopic, right?
So you're trying to elective
Whether the appendix was
incident.
acute or not, you remove it.
Okay, you're being more specific now. You're referring to incidental appendectomy. No, unless the same answer as with Dr. Pena, unless you have consent for an elective or incidental appendectomy, we don't just remove the appendix, okay, without any consent.
No, let us not bother about the consent. I would like to know how you feel about removing the appendix every time you go in.
That's why, Doctor, if there is no consent, I won't.
Just the consent you want.
May I give you comment? In your specific case of cesarean section, you would like to do an incidental appendectomy. I must remind you that the cesarean section is a clean operation, and an appendectomy is a potentially dirty operation. I would feel afraid to mix a clean and a dirty operation in this case because of previous experiences that I saw. I would feel I would not do an appendectomy even if it is with consent, as long as the appendix is not abnormal.
I'd just like to go back to your statistics where you mentioned about your series of right lower quadrant observed directly. How many were you able to separate, after about 24 to 48 hours? Was there a big gap between those that you were really able to diagnose as acute AP or non-initial causes?
About 85% were operated during the first day.
There was
There are only about 3 cases during the third day.
What I mean was that you were mentioning that at the initial onset, your diagnosis in fact was right lower quadrant tenderness and not necessarily acute AP.
Yes.
So among those series that you had, how many were really categorized in the acute AP level out of the column?
Out of the total, yeah, about 94% were really acute appendicitis.
So there was
94, 95, yeah, 5%.
because there are times when you are now saying that it might be acute AP. On further observation, the pain decreases and tenderness
Yes.
goes away. So I'd like to know that certain percentage that you have that kind of case.
Oh. The total number was 504. Okay? 259 were operated. So the rest were not operated because one of the reasons was that one, the pain disappeared. And
So
then,
I'd like to point that out also some for residents that it is not per se that when you saw a patient now,
for the first time.
yes, for the first time and your diagnosis was acute, on your re-examination, you would still push yourself even though the pain is not there anymore.
Yes, that's
So I'd
true.
like to point that out.
Thank you.
Is there any preference? Is there any preference of abdominal incision in cases of acute appendicitis and ruptured appendicitis?
Well, there is no, generally when you do acute appendicitis, I do also a right lower quadrant transverse incision. Transverse incision. I'm not worried about, because depending on your preoperative evaluation, if you feel that there is a very bad, severe peritonitis and you wanted to treat the entire peritoneal cavity, that particular situation, I do a midline laparotomy incision.
In rupture, that is rupture.
Generalized peritonitis.
Suppose the abscess is localized somewhere in the right.
I still do a right lower quadrant transverse incision. I feel I am confident I can clean the area also.
Doctor, going back to appendicial abscess, I didn't get your management of appendicial abscess. Aside from operating start on the patient, what will you do? Will you just treat the abscess or will you do Reynaldo for appendectomy?
So the first primary aim in operating on patients with a possible appendiceal abscess now is to establish the diagnosis if it's real appendiceal abscess. If you have established the diagnosis of appendiceal abscess, the second goal will be to treat the abscess. Third will be to remove the appendix. Okay? Most of the time you can remove the appendix. It's a little difficult, but most of the time you can. Okay? Don't be swayed by reports in the literature, especially those advocating conservative management that it's difficult to do appendectomy. Okay? After you drain the abscess, just feel for a tubular structure. Okay? Don't rely on your vision. It's hard to recognize the appendix just by looking. Rely on your palpation. Look for a tubular structure. Okay? And then if you feel a tubular structure, okay, presume temporarily or initially that's the appendix and try to remove it. Okay? And then you can check whether it's really the appendix if you can see a lumen at the point where you cut, where you make a cut. Okay? And that's the appendix. Okay? Before ectopic pregnancy, would you allow if you have a patient with ectopic pregnancy, ectopic pregnancy, it's an ectopic pregnancy. Poor diagnosis of appendicitis, but operated for that purpose, indication.